happy to visit your country, and in this time it should be virtual because of the situation, but I planning to come back as soon as possible because I enjoy very much visiting your country. So today we will talk about a management of deep bites and open bite with a aligner, with CA clear aligner, and then this is, first of all, some topics about particular things of our technique. So, what is different in CA clear aligner? Clear aligner covers 2 millimeters of soft tissues. So, we don't cut the aligners at the level of the gingival margin, and we cover a little bit more. And it is possible because we don't do all the aligners for 1 year or 2 years in the first, or taking into account only the first impression. And of course, it is not possible to do if you prepare all the aligners together because you cannot predict the changes in the soft tissues because it depends on the brushing, dental hygiene, etc. But we can cut at the level of the gingival margin. We call it scalloped margins in cases of patients with some gingivitis. And covering 2 millimeters, we are closer to the center of rotation of the teeth, so we get less inclination of the teeth and more bodily movement. Also, we change aligners every week since a lot of years ago. Now, most of the techniques are doing the same, but we do that. I have published in my books from more than 10 years ago. And we use 3 different thicknesses of aligners that we use: soft, medium, and hard, and also X soft, which is 0.4 millimeters. Normally, soft is 0.5, medium is 0.625, and hard is 0.75 millimeters hardness. But after thermomolding, the thickness is reduced to the half. So these are the sizes that we normally use. And doing that, using with the same setup model, but 1 week soft, 1 week medium, 1 week hard, we are maintaining the activation of the aligner, and we are producing a very fast movement because we are maintaining the density of osteoblast and osteoclast in the area. Also, there are some students that said that really it is much more effective than the normal technique with only one thickness, like this study in the Clinical Center Munich, Germany, or this another one from Gao, Bordier, and Bickelhaus. And the conclusion is the progressive thickness and to cover the gingival tissues get more effective movements. Also, there is another article from Fayez El-Kudi and Bern Lapatki that also said that different thickness are much better than only one thickness. So we take more impressions, and it is according to my philosophy PTMC, which is plan, treat, monitorize the treatment, and control. Why other techniques have much more aligners at the end than our technique? Because they check the results at the end of 1 year, 1 year and a half treatment. So in this moment, they need another aligners to finish in the case. So we need detailing aligners to finish the case. But as we take more impression, more scans of the mouth, we are taking a superimposition of the new impression with the step that we are, and we do it with the computer. And in this way, we are sure that we are maintaining the treatment time because we are not only planning the end, we are planning every 3-4 months where should we be, and we check it superimposing the new impression or the new scan with a step. So this is the philosophy of my technique. In fixed appliances, my technique is custom made to straight wire, and the treatment is plan, treat, monitorize, active. So in this way, we are doing a treatment that is always under control. So we don't prolong much more the aligners, and we finish, depending on the patient cooperation, of course, but no more than an increase of the treatment time in 10%. And we have not only aligners, we have a full system that includes the CAT pliers, and I have designed many different pliers to active the aligners. All my inventions are to reduce the treatment time, so we can active in the clinic and we can create more retention point in case it is necessary. And sometimes it's necessary, especially when the patient have a lot of prostheses or not much more teeth, so they have missing teeth, and we need to increase with retention point in between the contact, interproximal contact point and the papilla. And we can do these bubbles to increase the retention from the labial or from the lingual side. Also, we have another, the tip 2 plier is to create rotation point, so to active the rotation. And then it is normally not necessary in the frontal teeth because they are uniradicular, but sometimes, especially for bicuspid, etc. And we can create bubbles, and we can see that we prepare in the aligner the space in the other side to allow the movement. For labial or a lingual crown inclination, I create the tip 3 plier, and it is like an oval activation point, and we can create an oval bubble near to the incisal edge from the lingual or from the labial side, and it increase, of course, creating the space in the liner in the other side before, during the setup, but we can incline this much faster than with the other techniques like this. And also, I create the tip 4, which is the control of the torque. So it is like this shape, and we have to make this bubble close to the gingival margin, as you can see here, from the lingual to take radicular torque of the roots, or in the labial side to create palatal or lingual torque of the roots. Also, I have created the tip 5 and tip 6 that are now delivering by Show Company for contouring margins and for reducing the activation in case it is necessary. Also, we have the CA vector screws, and we have the vector 40 and 45 for anterior expansion. So we can do in 1 month the same that we can expand in 3 months with progressive setups. Vector 50 and 150 is for posterior expansion. Piston screw is for unidental expansion. Vector 30 I have created for lateral oblique expansion. And the vector 350 distalizing kit, distalization, and the vector 350 tractive screws closing spaces. So here we have the 40 for transversal expansion, as you can see here, and we active 1 turn of the screw every 2 days. Like this, only use it with the heart, with the 0.75. Then the vector 50, we have to cover the palatal surface, and we can expand the molars, like this. And this is the vector 30 that I have created for a lateral oblique expansion, so a diagonal expansion, like this, with a reinforce of a wire. piston screw was created by Professor Hinz, and it is like a screw with a coil spring, and we can active with a screwdriver. And then the distalizing kit 350 is to distalize first and second molar very easily. I have created this one with a screw in the lingual side and with a tube with a coil spring in the labial side. And we can use it in the upper or in the lower arch. And also the 350 tractive screw, which is to close the spaces. And we can move the teeth 1 millimeter in about 1 month, like this. And of course, the system is with an open screw, and we are closing this screw, and the tube is a guide, but of course, in this case, without the open coil spring. Also, we have the progressive stripping technique set that I have created to make the stripping. And plastic buttons, we don't make cuts in the margins of the aligners. We bond buttons for intermaxillary elastics with the cyano veneer and the pipettes. And then it is very easy to bond the buttons. And after 1 minute, it is perfect to be ready to use the elastics. And then we have the power grips that I have created also to achieve better movements. And I have created 9 different attachments. One is for multifunctional force movement, MDI for mesial-distal inclination of the root, the MI is for distal mesial inclination of the root. For force application labial, the number 4, the 5 force application lingual, and the number 6 to 9 can be used also with fixed appliances because they are to create the buildups. The 6 for bicuspid, the 7 for molars, the 8 for anterior small, and the 9 for anterior large. And this is the chart how to use them with elastics, etc. And these are molds that can be reused all the time that we need, or we can create in the computer and make a template, but we can make force extrusion, as you see here, with the power grip on the tooth and 2 buttons on the aligners, and of course creating in the occlusal part the space for the extrusion, also for rotation to measure or to distal, and the procedure to bond that is clean the tooth with a prophylactic paste, isolate the site with buccal separator, cotton balls, and aspirate like this, and then dry, apply the prime over the tooth with a brush, and then put any composite on the power grip, insert in the mouth, and then like cure it. So this is what you have. But also we have it in the software, so it's very easy to put, this is the number 1, and the half of the number 2, because the number 2 is like this, and number 3. Also we have here the number 4, number 5, and we can put in the digital model and create a template so the dentist can, or the orthodontist can prepare the power grips directly in the mouth. This is the build-up for bicuspid, and then build-up for molars, and then the anterior build-ups for central incisors and for lateral incisors. So we create templates like this to do the same in the mouth and to create with composite the attachments in the mouth. So The power grips number 8 and 9 are here in the palatal surface to create an artificial cingulum to allow the extrusion of the molar and to facilitate the intrusion of the incisors. And this is the distalizer kit that I told you before. And then we can upright the molars, and also we can move all the other teeth. For example, in this case, we are moving the cuspid, the canines. So in the anterior deep bite, which is the topic of today, we have the diagnosis of the gummy smile, the treatment plan that should be anterior, posterior, superior, inferior, to take into account the facial pattern, oral display, and rotation of the occlusal plane. And the treatment protocol is important, how much force we will apply, the torque control before and during the intrusion, and the sequence of movement. So here in the diagnosis of the gummy smile, we need an interdisciplinary approach, of course, and in case that we have a normal gingival insertion, but deep pockets, then we have gingivitis, and the treatment should be gingivectomy by the periodontist. When the clinical insertion is at the level of enamel, then we need a crown enlargement. If we have reduced overbite, gummy smile, and abrasion of fracture, we need orthodontic intrusion and a prosthetic crown. And for increased overbite is orthodontic intrusion. How much can we intrude the teeth? About 2.5 millimeters maximum in 3 months. No more, because if we try to intrude more, we can damage the apexes of the roots. So in these cases, maybe we need a surgical treatment. And when we use the power grips for anterior build-ups, we allow the extrusion of the molar if it is necessary. And also, it is very important because the force of intrusion is not only applying in the upper, but also in the lower. But also the force is more in the direction of the center of rotation. So in this way, we are controlling much more the torque that if we are applying the force only in the labial side, that during the intrusion, we are increasing the torque. When we have to extrude molars in brachyfacial patients, when we have to intrude incisors in dolichofacial patients. So to decide if we are going to treat in the posterior teeth or in the frontal teeth, we have to take into account the facial pattern. But to know if we have to treat in the upper or in the lower arch, we need to take into account the rotation, the inclination of the occlusal plane, because the treatment of the deep bite in the upper arch doesn't matter the appliance, always doesn't matter that you extrude the molars or you extrude the incisors in the upper arch, we are creating a counterclockwise rotation of the occlusal plane. And if you treat the deep bite in the lower arch, doesn't matter that you extrude the molars or you intrude the incisors, you are making a clockwise rotation of the occlusal plane. So the treatment in the upper arch is indicated when you have an initial occlusal plane, which present a clockwise rotation. And the contrary, you have to treat in the lower arch when you have a counterclockwise rotation of the occlusal plane. So to decide extrusion of the molars or intrusion of the incisors, we take into account the facial pattern, dolichofacial, brachyfacial, mesofacial. And to decide if you are treating in the upper or in the lower arch, doesn't matter the appliance. We have to take into account the rotation of the occlusal plane. Also, it's very important to use light forces. Never use more than 50 grams. Why? Because if you are applying harder, bigger forces, you are making a pressure over the apical basals. So if you make a pressure on the basals, you will reduce the flow of the osteoblasts and osteoclasts, and of course, you will get never the movement. Also, you can damage, of course, the apexes. And the torque control before and during the treatment is totally important because we can only intrude the incisors through the spongy bone, never to the labial or the lingual cortical bone. So it is very important to correct the torque and then intrude, but maintaining the torque. And for this reason, when you use a normal aligner, you apply the force more labial than the center of rotation. So during the intrusion, you are increasing the torque. But if you put my build-ups, then the force is more in the center of rotation and you are having much more control on the torque during the intrusion. It is so very important, and I published that a long time ago. Another techniques are using bite ramps in the aligners, so they are creating this shape in the aligners. But my power grips, I think, are better than the ramps because when the patient is not using the aligners, the power grip continues working because the pressure of the lower incisor over the upper incisor is also intruding the teeth. And in the case of this shape, only in the aligner, when the patient is not using the aligner, of course, it is not working. But at the end of the treatment, I maintain these power grips, giving the shape of a cingulum as a permanent retention. So if you intrude the teeth with a ramp and create this space, of course, when the patient stops using the retainers, the teeth without contact will extrude and will have a relapse. So when I put the power grips, when after align the teeth, when I remove that, never in the life, I give the shape of a cingulum and I maintain as a permanent retention for all the life. That's why I don't have relapse in these cases. So, for example, here we have a case with a deep bite and crowding, and you have to follow the sequence. First of all is ALR, which is alignment, leveling, and rotation control. After that, you establish the torque, and then you put the intrusion. Always this sequence. And for that, we have the power grips number 8, which is the build-up anterior small, BUAS, or the BUAL number 9, which is build-up anterior large. When we do that, we are creating a relaxing effect, like a relaxing splint of anterior contact. Why? Because the patient have a proprioceptive reflex, which is also protective. When you bite something hard, you stop biting. So the patient cannot bite all the foods, but they feel relaxed, not contraction for that. And we have two handle instruments with different direction for a better access. And we have here the bual, which is the large one for the central incisors. And of course, you can reuse it a lot of time. And the small for the lateral incisor, which is the buas, the build-up anterior small. So you put the power grips in the handle instrument, and then as we want to finish with an overbite of 2 millimeters, then you have here a mark to put the power grips, the composite power grips, in 2 millimeters. So you have here the buas, the small one, and you use any composite like this, and then you clean the teeth first of all with a prophylaxis paste, and you isolate the film. And of course, after that, you rinse and dry, and you acid etch the teeth. 20 second, 30 second maximum. Normally we aspirate the acid edge agent and then we rinse and dry, minimum 10 seconds per tooth. And after that, we will see these whiter surfaces, and then we apply the primer. Depending on the composite we are using, we have or not have a primer. And depending on the different manufacturers, we have to light cure the primer or not. In this case, we light cure the primer. And then you see that when we are putting the power grips, if you align the incisal edge with the margin of the handle instrument, you will have here 2 millimeters. So the power grip will be a cingulum 2 millimeters far to the incisal edge. So the final overbite will be 2 millimeters. So you put the composite, you remove the excess, and then light cure it. And then remove the instrument. And you have here totally prepared the power grip. We do the same with the 4 incisors. And here we have in the central incisors the buas, the bual, the large, and in the lateral incisor the bual. And then after that, you have to maybe polish some margin if they are sharp and adjust it with the articulation paper. And it is ready. Then you can go ahead with the aligner like this, intruding in the setup 1 millimeter per month. So it has a splint effect, a relaxation. When you bite something hard, you stop the activation of the muscles. So you have a relaxed effect. And you can also extrude the molars, and depending on the setup, you will intrude the incisor or you will extrude the molars. And to decide that, we have to take into account, as I said before, the facial pattern and, of course, the inclination or rotation of the occlusal plane. So what we do is we have the mouth, we take an impression. In red, we have the setup that we intrude the teeth 1 millimeter, and we adapt, we thermomold the aligner. So when we go to the mouth, of course, the aligner will not fit in the posterior teeth and also in the labial margins. And after some days, when they bite, then the aligners will adapt because the aligner intrude the incisor or extrude the molars. So this is the first day that you can see that in the posterior teeth, the aligner is not adapting, and also it's not adapting here in the labial margins. But after 1 week, the patient bite, and as they feel something which is soft, is like a bubble gum. So they try to bite, so they are activating the intrusion. And then after that 1 week, the aligner fits completely, and it means that when the aligner fits in the posterior teeth and in the labial margin, means that the effect was achieved. So we go from here to here. Coming back to our case. First, follow the sequence: aligner, leveling, rotation, torque, and intrusion. So these are the initial records. And you can see that especially the upper central incisors have a very negative torque. And if we intrude before correcting the torque, we will intrude to the labial cortical bone, damaging the roots, making an inhibition of the movement, or having much more problems like dehiscence of the cortical bone. So this is the initial in the computer, and we create the setup. And in the first step, what we will do is to align correcting the torque, so protruding pro-inclination of the incisors. Second is pro-inclination and stripping. Third, torque establishing, and then intrusion at the end. So in initial, and it's the same in the computer, of course. And then this is what we have in the computer. And we can see, of course, from all the point of view. And we see that now we have this deep bite. And after the first step, after using the first aligner, which are 3, soft, medium, hard, we change a little bit the torque and we start the alignment of the upper teeth and the lower teeth. And it is the same that happened in the computer, exactly the same. Step 2, we continue alignment leveling and rotation. And you see now a different torque of the teeth. Remember that at the beginning we saw more the labial surfaces. Now we are seeing also the palatal surfaces. And it's the same that happened in the computer. Torque establishing. You see now all the palatal surfaces. So now we have the roots in the spongy bone. And it's the same that happened in the computer, of course. Intrusion. Same in the computer. And final. Same in the computer. So we finish on time. And this is at the end. And you see that we have this separation. And of course, we need here to create the cingulum. If not, you will have relapse. That's why we maintain, in all the cases for all the life, the new cingulums. And you see here before and after, correcting alignment, leveling, rotation, and deep bite, and see the difference in the torque. Here, there are very vertical, and here there are with a good torque. And here is the same. Before and after, you see here the labial surfaces, negative torque, and you see here palatal surfaces, positive torque. And here we can see all the evolution of the treatment. So this is our protocol. But after 3 months, we can take a new scan of the mouth and we can superimpose to see where we are. And here, our software allow us to check if the torque have changed or not, superimposing. So we can see here which areas are superimposed, which areas not, from all the point of view. So we know if we are on time or the patient is not using the liners or we're doing too much or less activation. Normally in the setup, we move 1 millimeter per month, but some patients need 1.1, 1.2, and some patients can support less the pain, and maybe they use less activation like 0.9. Another case, which is the same protocol, always the same protocol, alignment, leveling, rotation, torque, and intrusion. So initial, negative torque, you see the labial surfaces, initial. And this is what we have with the deep bite. And then at the end, and then you see here at the end, before and after, before and after, before and after. Here, another case, same situation, deep bite, always the same protocol. Initial, final planification. So we have here the initial, and the end. And the end. And you can see here how we need really the power grips for the permanent retention. Before and after, before and after. Another case, same, always the same protocol. Before and after. Another case, always the same. So this is a system totally predictable. And at the end. Okay, open bites. Now we have vertical open bite with reduced overbite, and we can treat them with the forced extrusion and forced intrusion. Pro-inclination open bites, which are the vertical open bites are here like this, and pro-inclination open bites are like this. And which is really important is the tongue reeducation. So this is a case with a relapse of an open bite because the patient didn't reeducate the tongue. And then we can treat him in only one aligner, 10 weeks. So I put power grip number 1 in the 4 incisors, and I create one aligner hard with the space for the extrusion, buttons, and they use elastics, which is 3.5 or 4.5 ounces, 1/8 elastics, after 6 weeks and after 10 weeks. So it's very easy. And the patient can use it at home and during the night, and during the day they can use aligners covering the power grips and pushing the teeth. This is a patient that doesn't matter the aesthetic, is a lady with TMJ problems, especially pain. So she has an agenesia of the upper left lateral incisor and a microdontia of the other. Of course, I propose her a treatment opening the spaces for an implant and a crown to increase the size of the 12 and to put the 22. But for her, the only important thing is the pain. So the only thing that she needs is to extrude the cuspid, the canine, to get the canine guide to this side and then reduce the pain, giving some stability. So first of all, we use aligner to align the teeth. And after that, we put the power grip number 1. We create the space for the extrusion and 2 buttons. And we use 1 elastic, which is 4.5 ounces and 1/8. And after 6 weeks, the cuspid was totally extruded. So you can see here and here the difference in the canine guide. And after that, she used a relaxation splint and reduced totally the pain. Also, we have the forced intrusion, which include 1 button in the labial side, 1 button in the lingual side, and 2 slots in the aligners. And we use a, sorry for, they are building something in the other floor. Sorry for the noises. And then we have here 1/8 elastic. And in this case, we want to extrude the 11 and to intrude the 21. Only 1 aligner for that. So the force extrusion create the space, use 2 buttons and 1 elastic with the power grip number 1, as you see here, to extrude this one. And this is the force intrusion to intrude the 21. So here we have an scheme, how works the power extrusion, and here we have a scheme, how works the power intrusion. And then we can level both teeth in 5 weeks only with 1 aligner. But also we can intrude, for example, in this case, this patient has a missing second molar and you need to intrude this molar for to put up implant with a crown. You can see here the intrusion, the extrusion, and then we only use 1 aligner with buttons and 1 elastic. So in this patient that cannot use microimplant, we can easily intrude the molars. 6 weeks. And then you see now the intrusion of the molar. And this is another case of an open bite, also 10 weeks with power grip number 1, and then extrusion with buttons and elastics. And after 10 weeks, we could close the open bite. And we use, of course, permanent rotation with fiber thread. Then we can use during the day the force extrusion with the elastics, and during the at home, and then during the day we can cover with an aligner and extrude only with soft and medium, never the hard. Also, to train the tongue, we can put some bubbles in the anterior part of the palatal vault with the tip plier number 1. So the patient has this reference to put the tongue, the tip of the tongue in this place and to make the reeducation of the tongue. And here we have a pro-inclination open bite. So here we have a case with an open bite, and as she has a very severe gummy smile, I didn't want to extrude the teeth to correct that. So I will correct this deep bite with the stripping and retroinclination of the lower incisors. For that, I will use aligners and my progressive stripping technique. And then you see how the retro inclination, of course, increase the overbite. Progress 3, progress 4, progress 5, and progress 6. We couldn't fit totally the midlines because she didn't want treatment in the upper, but managing different stripping in one side, in the right side and in the left side, we can almost match the midlines. And this is a lateral open bite because an habit, she is a nail biting and tongue reduction, and we want to extrude these teeth. Of course, we make some occlusal adjustment by selective trimming to eliminate the interference and close a little bit more, but also I use the force extrusion with 2 buttons and the power creating the space, and with the CA power grip number 1. And then in this case, I wanted to extrude more the lateral incisor than the cuspid, so that's why I put the 2 sides of the elastic over the lateral incisor and only 1 part of the elastic on the cuspid. And then we could close very easily the lateral open bite. Before and after. So this is very, very easy with a very predictable system to manage the vertical malocclusion with aligners, especially the deep bites, but with elastic and power grips and buttons, it is very easy to manage also the open bite, as you have seen. So thank you very much for your kind attention. We have some minutes if you want to make some questions, and I will be very happy to answer the question if you want. Thank you very much, Basem, for your kind invitation again. Do you have any questions? I cannot hear you.
We will check now the...
Now, yes, now I hear.
One question about what is the sequence of the ALR? The question is, what is the sequence in the steps of ALR?
For what? Sorry, repeat me, please. The sequence for?
About the ALR, what is the sequence in the treatment plan?
In the treatment plan? Yes, first, for alignment and leveling, first of all, you have to create the space. So you can create the space for aligners by expansion or by stripping. It depends on the relationship of the occlusion in the upper and lower jaw. So if you have enough overjet to protrude the lower, or you have reduced overjet to protrude the upper, you can do expansion, or if not, you have to do expansion in both arches. For the stripping, we take into account the Bolton analysis, and we only do stripping in the arch that have a Bolton excess to compensate this discrepancy. So we create the space. After create the space, we make the movement, which is 1 millimeter per month, and then we finish the alignment, and then we go into the torque control.
Another question about the extrusion. How many meters we can extrude the teeth with
Yes, we can extrude no more than 2 millimeters. 2 millimeters is a limit in order not to have much problem. But of course, it depends on the periodontal status. I'm talking about patients with a good periodontal health. If they have problem in periodontal status, then we have to limit the, the extrusion or the intrusion according to the bone support and gingival state.
and
At 2 millimeters, 2.5 we can do that.
2 millimeters in all the
Yes,
treatment.
2 millimeters, more or less. But I have published some maximum movement for in all the directions that you can order the scheme from the Shoei Dental, and they have for the upper arch, for the lower arch, maximum movement, and if you need power grips or not to achieve this movement. Also in my books are published that information for in all the mesodistal direction, labiolingual direction, vertical direction.
So every month we can make extrude 2 millimeters, or in all the treatments. This is
No, in all the treatment,
all
in
the
all the
treatment.
treatment.
Every month.
But we active, well, every month we active 1 millimeter, but normally in the first step, we don't get too much movement, especially in adult patients, because we need to increase the density of osteoblast and osteoclast. So we do two setup of 1 millimeter, maybe 1 millimeter, 1.5 millimeter, 2.5 also is possible, but we need 3 months if the patient use the elastics to get the movement, to achieve the movement.
Okay. Thank you very much, Dr.
Thank you
Pablo.
very much, and see you soon for the course on November the 2nd.
Yes, very welcome. And we have an extensive course of Dr. Pablo Echarri about treatment plans in the 2nd of November. We are waiting for any interesting to participate, and see you again on 2nd of November.